Thank you very much, and thank you, Peter, for allowing us to be part of this fantastic mission. And I'm the leader of the critical care study group within the domain of translational medicine. And today, my second, PhD student is going to defend his thesis. They were the first birds in the critical care study group here at Semmelweis University, 6 of them, and Gergő is the second who is defending his thesis. Gergő graduated in Budapest at Semmelweis University in 2013, and then he started working at the Székesfehérvár Hospital as an emergency physician, also at the ambulance and also the air ambulance. So he's running 3 positions, and in 2021 he decided to join us in the critical care study group. And at that time Gergő had 2 children, and this just shows that how inspirational we are, that by the time he finished he has 4 kids now. So it's a fantastic achievement for all of us, and congratulations for Gergő and his wife who is here, and the whole family. So Gergő's vision and mission was to translate knowledge in emergency medicine and to improve outcomes. And he will introduce to you 2 of his topics that were published in highly ranked journals. One was his original idea based on the use of bedside ultrasound, the POCUS, in improving outcomes in patients who are admitted with acute chest complaints. And the second one was a joint project investigating the efficacy of balanced electrolytes versus isotonic saline in the treatment of patients who are admitted with diabetes mellitus and diabetic ketoacidosis. And he has a third project closest to his heart, and that investigates the efficacy of on-site transfusion in severe trauma when they are rescuing patients with the air ambulance. So this is an ongoing project. And all in all, I feel privileged to be the mentor of Gergő. He was an excellent worker, very constructive, very hardworking, very focused, and he was also a very good team member. So it was good to work with these 6 guys. At the moment, now we have 21 PhD students in the program, and we will continue. So with this, thank you for the opportunity to introduce Gergő, and I hand the stage over to him. Thank you.
Thank you very much, and yes, Gergő, the stage is yours, and you have around 20 minutes to talk about your PhD thesis.
Thank you very much. Dear committee, dear audience, my colleagues, let me introduce my PhD thesis, which title is Improving Outcomes in Acute Life-Threatening Emergencies. As Zsolt mentioned, I'm an emergency physician who works in Székesfehérvár in a hospital in the emergency department, and was also in 2 different pre-hospital emergency services. My vision in the scientific area is to provide the most appropriate care to all the patients treated in the acute phase, and to achieve this, my mission is demonstrate that scientific methods can be used to improve patient care. To do that, I've got 3 different projects. The first one is the usefulness of point-of-care ultrasound in patients admitted with acute onset dyspnoea. The second one, to find the most suitable infusion in patients who is admitted with DKA. And the third one is a retrospective study in cooperation with the Hungarian Air Ambulance team. Point-of-care ultrasound improves clinical outcomes in patients with acute onset dyspnoea. That was the title of my first systematic review and meta-analysis. We know that when someone is admitted to the hospital with acute onset dyspnoea, it means a high mortality rate, around 30%. Differential diagnosis can cause delayed treatment, and the conventional approach, what we learned in university, is often time-consuming and it may lengthen hospitalization. What I mean conventional approach, when arrive the patient, the first step, the inspection, then as the medical history, the anamnesis, then percussion, auscultation, consultation with different field of medical scientists, like cardiologists, radiologic expert, and so on. But we know that POCUS, that is the abbreviation of point-of-care ultrasound, can enhance early treatment, but evidence is uncertain, or let me say evidence was uncertain. POCUS is a handheld, mobile-size device. It's a bedside point-of-care modality. So it's a gadget to answer a yes, no question. Is there a fluid? There is no fluid. It's used by a non-radiologic expert, usually emergency physicians or intensivists. It's a bedside, easily repeatable, and not expensive attitude. The aim that our study assess the efficacy of POCUS versus conventional approach or length of hospitalization in patients admitted with acute onset dyspnoea. Our clinical question, does POCUS usage reduce time to diagnosis, time to treatment, and length of stay in patients who is admitted with acute onset dyspnoea? To answer that, we used the well-known PICO framework, where P is the population or patients who is admitted with acute onset dyspnoea. The I is the intervention arm when physicians used POCUS. The C, the control group, where physicians did not use the POCUS, only the mentioned conventional diagnostic methods. And I show you our primary outcomes like time to diagnosis, time to treatment, and length of stay in hospital, and secondary outcomes as mortality, readmission rate, and rate of appropriate treatment. It was a meta-analysis, so for more than 11,000 articles, finally 14 of them were suitable for data collection. That is our primary outcome, time to diagnosis. On the left column you see the studies with the author and the date of publication. In the middle the POCUS arm, and the control arm, and if we summarize this forest plot, we see that more than 1 hour time reduction could be achieved when used POCUS compared to not use it to make a diagnosis, which is statistically significant and clinically absolute relevant outcome. After when we got a diagnosis, we can start a treatment, and based on our results, nearly half an hour time reduction could be achieved when used POCUS, which is also significant and very considerable result. After when we got a diagnosis and started the treatment, there's a judge question whether our treatment was appropriate or not. And based on our result, we can say that yes, when you use POCUS, you can ensure your patient a 2.3 times higher odds to receive an appropriate treatment compared to the control arm, which is a huge result, I suppose. Secondary outcomes, like 30-day readmission rate, we found no significant result in that outcome. Also, there was a tendency favoring the POCUS, and it was also true for in-hospital mortality, and it's easy to understand because POCUS is only a diagnostic step, and it's very rare when a diagnostic approach has a direct effect on mortality itself. Length of stay regarding the ICU, we found that patients who was examined with POCUS received more than 1 time long stay in the ICU, which is important in our daily practice and statistically significant result, and take into consideration that ICU is a very expensive and dangerous part of our hospital. To sum up, from 14 studies, more than 5,300 patients, we found that POCUS can reduce time to diagnosis, time to treatment, can decrease the length of stay in the ICU, and improve the rate of appropriate treatment compared to not use POCUS. We published our result in a high-quality journal. My second project's title is Fluid Resuscitation with Balanced Electrolyte Solution Results in Faster Resolution of Diabetic Ketoacidosis, DKA. than with 0.9% saline in adults. That was also a systematic review and meta-analysis. We know that DKA require more than 500,000 hospital days per year in the USA, and fluid resuscitation is one of the cornerstones of early management. The two others, the electrolyte balance and the parenteral or any other way of insulin administration. We know that the guideline still recommend 0.9% saline or give the freedom for clinicians to use balanced electrolyte solutions. We know that the disadvantages of saline, that it can cause hyperkalemic metabolic acidosis, can change the inflammatory system, and can cause to impaired renal function. In contrast, balanced electrolyte solutions contains electrolytes in more physiological level, thereby improve acid-base balance and may lead to better outcomes. But theoretically, it can cause hyperkalemia. Or question, that does balanced electrolyte solution compared to saline administration shorten time to resolution of DKA in adults? Again, the well-known PICO framework. So the patients, adults only, who was admitted to the hospital with diabetic ketoacidosis, the intervention arm, when they received balanced electrolyte solution, in our daily practice we know them as plasmalite, Ringer's lactate, isolite, and so on. The control arm always when they received saline only. Okay, and outcome, the primary outcome is the most important, that is time to resolution, and I show you secondary outcomes in the forest plots also. From 7,000 articles, more than 7,000 articles, finally 10 of them were suitable for data collection, and based on that, we found that more than 5 hours time reduction could be available when the patients received balanced electrolyte solution compared to saline, which is statistically significant, and it's a daily practice also a large result, I believe. Secondary outcomes, change in different electrolyte levels, like post-resuscitation chloride levels. You see, although it's statistically significant, but in a daily practice, 4 millimole per liter difference is absolutely not relevant. It's true also for the sodium levels. 1.4 millimole per liter difference is not significant in a daily practice, although statistically it was. And it's also true for bicarbonate levels. We found no significant difference regarding the potassium levels, and some other outcomes like duration of parenteral insulin administration, we found no significant difference regarding that outcome, although there were a tendency a little bit higher in the saline group. And that was also true for the amount of total fluid administration during the resuscitation. There was a higher amount in the best group, although it was not significant. Hyperkalemia is a rare side effect. There was no difference in the two arms. It's also true for hypoglycemia. So implication for practice. We believe that patients who is admitted with DKA should be treated with BUS in order to shorten time to DKA resolution and optimize some electrolyte and bicarbonate levels also. But there's an important implication for research, that furthermore homogeneous and better prepared studies are needed where patients' data collection follow the same structure. Sum up, our study was a fill-in-the-gap study from 7 RCTs and C observational studies. It was the most comprehensive meta-analysis when we published it, and we included adult patients only. Other studies included children, but we believe that they are two different populations. The limitation is the low number of patients, the different DKA resolution definitions in the studies, and the incomplete data reporting in some cases. We can conclude that balanced electrolyte solution seems like a preferable infusion over 0.9% saline resolved DKA in adults. We published the results in a high-quality journal. And the third study, what Jolt also mentioned, is the CHOPPER study, critical hemorrhage and pre-hospital red blood cell transfusion. We do it in cooperation with the Hungarian air ambulance team. It's a retrospective study. We know that injury is the leading cause of death in adults and children between the age of 1 and 44. In major trauma, bleeding is one of the main causes of death on the scene or in the first 24 hours. It's responsible for 30% of dying. Results about the effect of pre-hospital transfusion are controversial. The majority of them arise from the military services. Our study may add that Hungarian air ambulance, the HAMS, can transport 2 unit zero-negative red blood cell to the scene of the accident, and we can begin the transfusion on the scene or during the transport, so before arrive the patient to the hospital. The aim of the study to assess the efficacy of pre-hospital red blood cell versus conventional approach or mortality in patients admitted or treated with massive bleeding. Based on the HAMS SOP, transfusion is indicated if massive bleeding is suspected. So I want to highlight that it's a clinical diagnosis, so no exact numbers. So it is suspected, and blood pressure can only be maintained in a target range with fluid boluses and or vasopressor. We prefer noradrenaline or push-dose Tonogen. And the rare indication when circulatory arrest happens within 10 minutes of HAMS team, HAMS crew arriving to the scene. Again, the well-known PICO. So we evaluate the result of patients who suffered catastrophic bleeding. The vast majority of them had trauma. Not all of them, but majority of them. In the intervention arm is the time after 2019, when red blood cell is already available in our country and can transport it to the scene of the accident. So it means around 130 patients from our database. We carry the blood on a special, let me say, fridge with fibrinogen. In the control arm is the period before 2019. So in that time, red blood cells were not available, although these patients were indicated for transfusion, but it was impossible. And our primary outcome will be the 24-hour mortality, because we suspected that this outcome is a hard outcome, and it is less influenced by the local protocols of different hospitals who treat the patients. And some other secondary outcomes like transfusion, amount of red blood cell in the first 24 hours, the rate of ROSC, return of spontaneous circulation, and so on. Where we are now, we do this study in Hungary. It's a nationwide study from Győr to Debrecen and Miskolc to Pécs, from 15 centers. And you see that in the intervention arm there is 170 and the control nearly 200 patients. Now we are in a data collection phase, and this everything will happen in the best way. We suppose that next spring or autumn we can publish or see the results. To sum up, all of my projects focusing on the acute phase. The first one is the point-of-care ultrasound. The second is the most appropriate infusion in patients admitted with DKA, and the third one is the effectiveness of red blood cell transfusion in the Hungarian air ambulance. And another mandatory part of the presentation is the scientometric. Of course, there are some data about the impact factors, but I suppose what is more important, of course, the presentation, Semmelweis Symposium, Amshotka, meeting with other HAMS research, but I try to give and show this attitude to my colleagues where I work, for residents, younger colleagues and others, to use POCUS and be innovative. I suppose it's also important, like a presentation. And I want to say thanks a lot for my professor, because without his contribution, it wouldn't be possible to achieve these results. And it's also true for all the SMSs who helped me a lot especially in the last part, Marius, who we work together, but all the others, thank you a lot. And also the whole staff of the CTM. Although I remember that when I presented my first forest plot, Peter helped me personally to help understand how to evaluate and how to present the forest plot, so I will never forget it. And thanks for Hams, and also thanks for my wife who gave background for do that and give me the advice to join Zsolt group, not to another one. I want to thank you for your attention from the quote from the Bible. What do you have that you didn't receive? Thank you very much.
Thank you, Gergő, and we learn again that ladies decide always, as usual. Okay, our next job to ask the opponents, and let me first ask Tihamér Molnár to review Gergő's PhD thesis.
Thank you very much. First of all, I always knew that the critical care domain is very strong here, under the leadership of Zsolt Molnár professor, because I knew him from Pécs. We were colleagues at the same department, and I'm also very thankful for Zsolt's support. Congratulations to this excellent talk. Sorry. Actually, the message of your findings, I mean, is very strong to the medical audience. And interestingly, using POCUS is very good in terms of getting the right diagnosis, because it was faster, more than 1 hour compared to the conventional tests. But interestingly, the initiation of an appropriate treatment was not similarly fast. The mean difference, as far as I remember, was 20 plus some minutes. So what would be the reason between this difference? What is your view about it?
First, thank you for the question. First of all, not the same studies published results for that outcome. So that's a great limitation to handle the results. On the second, in our daily practice, we saw that there could be a delay between receive diagnosis and then start to treatment. It can influence by local protocols. What I mean, when a resident or any kind of physician get a diagnosis, perhaps they need to consult with a senior which treatment would be the most appropriate. So that could be a factor behind this difference.
Yeah, my second question connects to your answers, because POCUS is very operator dependent,
Definitely.
the result of POCUS. So the training of the staff, the operator, is very important. Also the quality of the device. And I mean, as I mentioned, your message, your findings can facilitate some change in future guidelines, but I mean, we need protocols when we want to use POCUS. And also there are some limitations. Let's think about obesity, obese patients. Can POCUS similarly accurate in obese patients when you would like to detect pleural effusion or cardiac failure, etc.? What is your opinion?
I cannot answer you from the literature, only from my practice. So, of course, obesity could be a limitation factor, but we change the deep of the ultrasound. We can receive the most appropriate picture also. But other limitation, which is much more important, is the operator dependency. as you mentioned, that is definitely, even though the duration of POCUS and the interpretation of results. And then the third, that POCUS is not the best choice in some conditions. We must evaluate the result in a different way when someone is respirated with positive pressure, or there is a compartment syndrome in the abdomen. These could be limitations, of course, but focusing on the chest, 99% of patients could be evaluated with this. And training also is absolutely highlighted important message. We wanted to present in the paper also that training, because one day training could be enough to make, I don't know, 90x% appropriate diagnosis with the POCUS. Of course, with supervision with the senior when it's necessary in the life-threatening conditions, but usually it's an easy-to-learn method. Not on the level as a radiologic expert, of course, but to answer a yes-no question, is there a punctuable pleural effusion or not?
And finally, my last question is, POCUS is used to diagnose cardiac failure, pneumothorax, pneumonia, pulmonary embolism, etc., pleural effusion. What do you mean? Is it reasonable to create homogeneous subgroups and assessing the efficacy of POCUS, I mean under efficacy, the sensitivity and specificity for each subgroups respectively? Is it a meaningful question?
Definitely, it's absolutely meaningful, and we found when we wrote the manuscript that there are a lot of systematic reviews and meta-analysis also handling this question, the accuracy, the sensitivity, specificity. So that's why we didn't touch this, but there are a lot of studies evaluating it and found that in different conditions there's a different sensitivity and specificity, but it's a usable method in a daily practice.
Thank you.
Thank you very much, and let me ask the second opponent, Ivica. Sorry.
Ivica Gergőrevics.
Gergőrevics. Okay, it's your turn.
Thank you very much. Congratulations, very nice presentation, and I think you clearly demonstrated the data which are summary and an analysis of the previously collected results from other studies, and this is the added value of the meta-analysis. So my question regarding your first investigation would be okay if so. I'm a great fan of the ultrasound, and I think it is very important to use it in the clinical practice. It is a very good tool to give you some immediate answers, including the bedside ultrasound, such as POCUS ultrasound. So, but one thing which is, I think, important to discuss, and I would like to ask for your opinion. So you demonstrated that by using POCUS ultrasound, it has favorable impact on several outcomes that you have investigated, except for the hardest one, which is mortality. So although you touched briefly upon this question or this answer, I would like to hear from you, what do you think, what is the reason why in your study you did not have results in terms of a better outcome of the patients who underwent POCUS during their diagnostic workup?
Thank you for your question. There were not so many studies which focused on that outcome. Only one. On the second hand, those patients who suffer dyspnoea, especially severe dyspnoea, has several diseases quite often, and these diseases will not change in the first 6 hours. We can start the treatment quickly, and we can influence the outcome somehow, but not the whole disease itself. There's a cardiac decompensation which happened days or weeks, and we start an ultrasound within 2 hours and give some diuretic drugs or anything else what is necessary, the patient condition will not change within 1 hour or within minutes until we treat them on the emergency or in the first day in the ICU. And I want to highlight again what you already mentioned, that it's a diagnostic approach only.
Okay, and then to extend to this question, and also to extend to Tichomir's question and discussion. So, if you have to consider designing the study which will address the issue of the impact of the POCUS ultrasound on the outcomes in terms of mortality, how would you design this study? So what would be your idea to make this study?
I was never in that position. In this study, we focused on that fact that patients who arrive with dyspnoea are not aware of the exact diagnosis. I mean, everyone suffers lack of enough breath, who has pneumonia, heart attack, heart failure, PTX, pneumonia, and so on. So make subgroups could be a choice, but not in the first step, because the emergency attitude, the ABC, airway, breathing, circulation, is similar in all the patients. And our attitude to make a quick diagnosis and then start an initial treatment is also similar. So I didn't think about that question, but I don't think it would be the most important to make subgroups. Although we can distinguish like trauma and non-trauma patients, or a known previous medical history like pulmonology disease, COPD, which is most often in Hungary, or even cardiologic background. That could be a way of separation, but no sophisticated, because it's not feasible in a daily practice in an overcrowded emergency.
Thank you very much. And let me ask the audience, is there anybody who has a question? Until you are thinking, let me ask first about the first topic that I wanted to ask how much is the learning curve for POCUS, but you already said that it's very rapid. It's only 1 day. That's pretty short. And is it only a chest ultrasound? I mean, it's ultrasound of the lungs, or you also examine the heart or the abdomen? So what is the rate of diagnosis
yeah, thank you. Thank you for your meaningful question. It was heterogeneous in the studies. Majority of them used the called 4-Pizzali method or the blue protocol, which focused on the chest, the pleural effusion, and an interstitial fluid in the lungs. There were some studies which added some beginner and quick cardiac echography steps, not a whole total cardiologic expert. And in some cases, usually we evaluate the vena cava inferior, the collapsibility, and when someone has a cardiac arrest or any life-threatening condition, we can also evaluate the large vessels, like the safena, whether there's a thrombus or not, and there could be a fact behind the disease, pulmonary embolization, for example. So the majority of them focused on the chest.
I see, thank you. My second question relates to your second topic, is that you mentioned this balanced electrolyte solution. It turned to be very good because we used a lot of things in the care of DKC. but there are several things which may modify the results. First of all, the severity of diabetic ketoacidosis, which you didn't mention at all. The second thing, we didn't have an idea about what was the criteria of resolution of the AKC. And my third point is that this balanced electrolyte solution is a heterogeneous group. So what was the composition of the different solution, or was there any difference between them in terms of the composition or in terms of their effects?
Thank you for your added comments and questions also. We highlighted also that facts in the article, and we published separately, article by article, that there were different definitions of the severity of DKA, especially anion gap, level of pH, and so on. Secondly, there was also a difference in the definition of resolution, and local protocols also. And yes, balanced electrolyte solution is a heterogeneous group, and for example, that could be a disadvantage of that fluid, that the buffer part of that, like acetate or lactate, can cause some harmful effect on the body, but we didn't separate that outcomes in our study. There were definitely enough data for that.
And for the clinical practice, which one do you recommend for the treatment?
Which kind of balanced
solution? Yeah. Just to learn something for my everyday practice.
Which is available in the local hospital. Because the main problem that in the majority of hospitals, perhaps not in this area of the world, but in other, the saline is the most frequent. That's why that could be a factor why guidelines recommend that one, because clinicians had a huge amount of practice with that infusion, but not the others.
So I would like to congratulate you. This is very interesting, these studies that you presented, that they really have impact on clinical practice. Now, it's probably too short to have only 1 day practice in point of care ultrasound to be sure that what you see is really relevant. So I wonder, do you have in Hungary protocols for POCUS that are well established, and also what's really the training that you have? And then the other question is, if this is only focused on dyspnoea and chest pathology, how many of these patients in the end up at CT, emergency CT? Because in my experience, most of these patients end up in CT eventually.
Thank you for your questions from our daily problems. I'm not aware nationwide and nationally accepted protocol in our country. There are protocols from abroad, which is easy to learn and easy to use. What I mentioned, for example, the blue, or in traumatic patient, the RUSH, the FAST, the EFAST protocol, and so on. But the main problem, yes, only one factor is the lack of protocols. But there are protocols which exist, and in the 21st century, physicians can learn them from the internet, and there are congresses and courses also. But the main problem is the lack of wish from physicians to do this attitude, because they learned, perhaps the older generation, waiting for the results from the checks history, because we can check it later, 2 days later, how changed the pleural effusion or the pneumonia or anything else. And one added information that to be an emergency expert or intensivist expert, it is mandatory to visit course, POCUS course. And your second question, how many patients or which amount of patients received CT? I don't remember there were data for that in the articles, but in daily practice, it also depends on which hospital you work. So in a In a large hospital where there are sometimes 2 CT, it's more easy. But in a rural hospital where there is no radiologist at nighttime, there is no telemedicine possibility, it's not easy to ask a CT.
The last chance to have a question to Gergő. Please.
Hi, I'm László Lújber from Pécs, Hungary. I don't really have a question. I just would like to ask a comment from you that you talked about POCUS, and I would like to join Dr. Csákó's comment that this ultrasound can be done only by for the chest, but probably it's also good for the abdomen and for the other internal organs. And I think on your third topic, you were talking about blood transfusion to those who you suspect a blood loss. Wouldn't it be possible or good chance for a study maybe or for a research to see if this POCUS is good for to assess the bleeding loss of the abdomen or the other places, and then obviously then use it for asking or thinking whether you should give a blood or not, because that would be ideal if you have it on board on the chopper, then you can have it done on the abdomen. Obviously it needs training and so on, but if you have the instruments, why not to use it for that?
Okay, thank you. Helicopter, we got POCUS, point of care ultrasound, and we can use them, but not in this population. So it's a clinical judgment based on the history, the severity, the type of crash, and the responsiveness of the patient. So first we give fluid bolus and then re-evaluate. And whether other boluses or vasopressor is needed, then we start the transfusion, we can start. POCUS is a quick but a time-consuming method. So we've got limited time to transport the patient within the first hour, the gold hour, to the hospital to receive damage control surgery. And we can do the ultrasound during the transport. So not on the scene, but during the transport. And secondly or thirdly, to evaluate the abdomen is very tricky, because with an ultrasound, I'm not radiologic, but it's not the best choice to answer there's a fluid in the retroperitoneum or not. You cannot exclude the fluid, huge amount of fluid in the retroperitoneum with this budget. And there's a very strong light on the scene, so it's not a dark examiner room when we do it, you know.
I have one question. I mean, first of all, I mean, congratulations. I mean, this is great, really. I mean, and also in the last one, I mean, that teaches us that you must ask very simple questions, and these simple questions are very, very important. So don't dare to ask simple questions. But so you have actually a cutoff here. I mean, before and after. I mean, giving the red blood cells. So are there other changes in the protocol? Because if there are other changes, then maybe the others could affect. I mean, this is still important. But so can you tell us something about this?
Thank you. That's a great idea, and we handled with this during our project. There was no fundamental change in the protocol from the part of the hem screw, but there was a moderation from the coordinator who sent the helicopter to the scene. So we want to treat those patients who suffer major trauma, because we can give the most dose patients, not for any kind of hypertension or bleeding. So that's why there was some change in the number of missions during this period, and yes, some drug change, or for example, we can use now invasive blood pressuring, and it was not available before 2019. But these are minor changes in this study. Thank you.
So one very short comment. So we keep saying that ultrasound is operator-dependent method, which is I believe the reason that some of the results, scientific results, when you analyze the studies with ultrasound, especially with POCUS, might not be that reliable. Okay, but if we have the people who are properly trained to perform POCUS ultrasound, then I think this is not operator-dependent method. It is very exact method, as exact as, for example, CT scan. Okay, so this is the important thing, and I think the important message from your presentation is that that you have results saying that using ultrasound might improve some outcomes of these patients. People should use ultrasound and should be properly trained, and therefore I think one of the messages from your doctoral thesis should be that people should be encouraged to use the ultrasound after appropriate training, and then it is not operator dependent.
Thank you.
One more remark from Tiamir.
It is also just a short critical comment in relation to the last part of your presentation. It will be very interesting, but if you have, because it is a retrospective analysis. If there is a significant asymmetry in the number of hypothermic victims in the two arms, how could you avoid this bias?
Hypothermic?
Hypothermia.
Yeah.
Hypothermia.
Yes, yes.
So, with other words, each of the included patients' temperature was assessed?
Yes. From the part of lethal triad, what we well known in daily practice, acidosis, coagulopathy, and hypothermia in patients who suffer catastrophic bleeding. It's called the death triad. We measure core temperature during the transport on the helicopter. It is mandatory to measure, but it does not happen in all cases. You know, it's a hurry-up situation. Go to hospital, give all the drugs what is necessary immediately, and avoid interventions and diagnostic step, which is not absolutely vital, like temperature. So in the data collection phase, we mark the column for core temperature, but I will not analyze that because there is absolutely no enough high-quality data. It's a great limitation, of course, and there will be a lot of limitation with that retrospective study.
Okay, thank you.
Is there any more remarks, questions? If not, let me ask the opponent again that do you accept Gergő replies, answer, and do you consider him or his PhD thesis appropriate for awarding a PhD degree?
I accept each answers.
Ivica?
With pleasure, I accept, yes.
Okay, we will have a committee meeting and then we decide about your PhD degree, and thank you very much. I wish to ask you to please stand up and let me start with Gergő Vilmos Szabó, and I'm happy to announce that it was a successful PhD defense and you got 100% of our votes, so congratulations for this.